we want to sort of remind each other, fellow colleagues, in how we are supposed to manage abnormal Dopplers at a gestational age, and also what to consider the importance of taking history or knowing the history of the patient before you start scanning the patient. Like what Dr. Verenga always says, that you're not supposed to scan a patient that you doesn't know. You have to know the patient that you're scanning, meaning you have to know the background, the medical history, the social history of that patient. And also how best we can diagnose or differentiate some conditions is in FGR, in fetal growth restricted babies. And to add on to that, well, we also, on this case presentation, we managed to find out that it is important to note some of the associated abnormalities that we find in mothers with polyhydramnios. Yeah, so yeah, basically, it's all about the reason that we decided to do the case presentation. So I'm going to start the case presentation. It's about a 38-year-old woman who presented in the FMU department at a gestational age of 3 weeks. In fact, this woman booked a pregnancy at 31 weeks at a local clinic, and she was referred at Mugabe Maternity Hospital due to elevated blood pressures. So in FMU, she reported at 32 weeks. It's when she had a first scan. She's a para-5 gravida 6 with 4 children at home, and unfortunately, the other pregnancy was a stillbirth. She's a non-hypertensive patient who was on losartan and nifedipine at the time of booking. That was around the gestational age of 31 weeks. So the attending obstetricians changed their drugs to methyl-dopa and nifedipine. And in every scan in the FME department, 32 weeks had the following finding: early onset FGR with abnormal umbilical artery with abnormal umbilical artery. So in the there was a decreased diastolic flow in high PI, and the rest of the fetal Dopplers were within normal limits. In addition, this patient had oligohydramnios, which had with a single defect pool of 8 millimeters. So I'm just basing this on assumption that the fetal anatomy was could not be performed well due to the reduced liquor volume. And the plan was to admit in the early labor ward. There is a unit in the Mugabe, and emergency delivery was ordered. Emergency delivery by cesarean section was ordered, and patient was also prescribed to be ordered to be given some antenatal steroids and IV magnesium sulfate. So unfortunately, the theater was busy. And the cesarean section could not be performed. Patient remained in the ward for, I think she was 34 weeks, and a repeat scan was ordered at that particular gestational age. The findings on the second scan in the FMU, there was polyhydramnios. Polyhydramnios was noted, yes, with single defect pool of 123 millimeters. Okay, so let me just so you can see the image on my left. there's okay, there is okay, it's on my right. Sorry, it's on my right, showing the vertical measurement of the deepest pool of amniotic fluid, right? And you can see that there are no fetal parts present there. So the deepest pool was around 122.9 millimeters, which is which is classified under moderate polyhydramnios. Okay, sorry, okay. And also, it was very difficult to visualize the stomach bubble on the second scan that was done in the FMU. It was very difficult to visualize the stomach bubble there. So, like, okay, you can see on this image here, though it wasn't really clear, but it was very difficult to visualize the stomach bubble there. FDR was noted, but this time the Dopplers were within normal limits. The estimated fetal weight remained was below the percentile. So the plan was to have a touchy screen done, and then see. And the patient was booked in the defect clinic for further assessment by the specialist. So in the defect clinic, the findings there were quite a number of abnormalities that were noted. Okay, and let me just show you some of the images that were managed to be captured. There was microcephaly, right? We can see that the baby had small head. The head was below the face central, and on the stomach, on the abdomen. The stomach bubble is not visualized. We could not. You can see that is the stomach bubble. It's not being visualized clearly because in normal circumstances, there should be a fluid-filled stomach bubble, but in this case, we can see that there's no fluid-filled stomach bubble. And they also in the fixed clinic, they also discovered that there's also tracheoesophageal fistula, and polyhydramnios was also noted as an abnormal umbilical Doppler. The management was the mother was supposed to have amniocentesis and OGTT and touchy screen as well. So unfortunately, some counseling was also offered, and the findings were also explained to the couple. And but unfortunately, the couple did not have funds to have all those procedures done, and the couples then reported back at Mugabe admissions after the mother had got into spontaneous labor. That was around the gestational age of 37 weeks. And she delivered a live baby boy with an upper score of 510, and the birth weight at that particular time was 2,100 grams. the baby demised after 48 hours in the 48 hours of life in the neonatal unit. So that's all about the presentation. Let me just show you some of the images. Okay, so the first one here, you can see it shows the deepest pool that was measured. So in this image, it was around 154.1 millimeters, which is classified under moderate polyhydramnios. And I guess we all know that when we have cases like when you've managed to have this kind of deepest pool, they are that is moderate polyhydramnios, right? So they normally the baby will be having some fetal abnormalities. This case, unlike the mild one, unlike the mild polyhydramnios. On the second image, there is the fetal heart. Then the following image, you can see that it was we couldn't visualize. It was very difficult to see a fluid-filled stomach bubble, stomach image, and this one has the 3D. Then on the nasal bone, okay, the baby had the nasal bone was present, and it was within normal limits, considering the gestational age. Okay, those are part of the spine, and also the kidneys were normal. The heart, okay, and okay, that's the posterior fossa. There the TCD. Okay, I forgot to comment on the TCD. That's the transcerebellar diameter. It was below the face central as well, and but the cisterna magnum and the knuckle fold were within normal limits. And the other image there is the image of Dopplers, umbilical artery Doppler. You can see that there was decreased end-systolic flow. The waveform shows the decreased end-systolic flow. And yeah, there was also the reading had also the high pulsatility index. Okay, the lateral ventricles were within normal limits. They were normal. Okay, so this is another image of the abdominal circumference, which was taken. So you find on these images of the abdomen, it's very difficult to visualize the stomach itself. You can see there, you can see the part of the vertebra, the umbilical vein, but when it comes to the stomach, it was very difficult to visualize on that. Unfortunately, I couldn't get the images of which would show the part of the esophagus and the trachea, so that you know, I think Dr. Verega will come in and help us how best we can you know, come up with how best can we really diagnose or tell that there is esophageal fistula. So that's basically about the case presentation that we had. So like what I said earlier on, that this case presentation is going to be more of a discussion. How basically, like when you come across such cases, how best can they be managed? Yes, especially if we happen to come across in the fetal medicine unit. And was it the proper management that was done from the time that the patient was seen, was first seen in the fetal medicine unit? So I'm going to leave this floor to Dr. Verenga to have a sort of an open discussion for this case presentation.
Thank you so much, Sister Chamba and the team there. Well done. Like Sister Chamba is rightly pointed out, let's hear what other people think of the case. Either you can, I think admin, people are able to unmute and speak, right? Those who are not able to speak probably because of where you are, please type what you think. We just, for the next 5 minutes, we want to hear what other people think. What is going on? Why suddenly we have this situation? The woman is on losartan. At some point, losartan is changed, and now she has polyhydramnios, and there may be some defect of some sort, and the baby didn't make it. Yeah, so the floor is open. Thank you. Kindly, okay. Yeah, so the admin is telling you that you can unmute yourself and speak.
Okay, we can see that Dr. Madembo is raising his hand. Dr. Madembo, you can go ahead and
Okay, thank you very much for the beautiful presentation. I have two questions. The first question is to do with the decision to deliver at 32 weeks. You said there was a decision to deliver, but theater was busy. Probably, maybe. My question is, what was informing the decision to deliver at 32 weeks? Then the other question is to do with the dating of the pregnancy. You said you first saw her at 32 weeks and suspected early fetal growth restriction. I'm not sure if she had no prior scans. I'm not sure, did she have scans done before, which we could use as baselines to now be very sure that she was 32 weeks and had early growth restrictions. Yeah, over to you. I think those are my questions.
all right. Thank you, Dr. Madembo, for those points. And I'll answer your second question. Sorry, I'd forgotten to highlight that she had a scan that was done outside FMU, which was done around 18 weeks. So the woman was dated using that first scan, which was done at 18 weeks. At 18 weeks. So and on your first question, yeah, this is one of the things that we wanted, this case to be presented with some of the plans that are being ordered, after, seeing such kind of patient with FGR, the diagnosis of they are in abnormal Dopplers. Is it really necessary? I mean, like, just to deliver it, even if is one of the Dopplers is abnormal. So those are some of the facts that we want to discuss. That's why I say that let it be. It's going to be more of a discussion. Because but what I'm thinking, maybe the reason why they ordered liver, maybe it was due to the oligohydramnios in the abnormal Dopplers. So that's why I had highlighted initially that it is very important for one to know the history of the patient before you can, whether this patient is on any medication or any chronic illness. You know, like in this case, this woman was on losartan and nifedipine, right? And so, like, as medical people, I was thinking maybe it would be very important for one to know what really, you know, like losartan do, the effects that they have, you know, to a pregnant woman, the effect that they have in pregnancy. And the effects that they have in pregnancy. So I don't know, let's just have a discussion on those.
Okay, noted.
Thank you so much. Any other thoughts? Can anyone explain what's going on here with the case in simple terms? What causes FGR to be associated with polyhydramnios? That's some kind of they're asking. Yeah, I think the question will be answered. But I thought in this case, the explanation is that the stomach bubble wasn't well visualized, so we are thinking that the baby is failing to swallow. Whenever there is polyhydramnios and FGR, it's not a typical FGR by the sheer definition of what an FGR is. Remember, the strict definition of fetal growth restriction is that there should be no fetal abnormalities on the baby. Once there are abnormalities on the baby, the suspected abnormality takes precedence over the diagnosis of FGR. For example, in this case, you saw that we lined up a number of issues we thought were going on. While the stomach was not clearly visible, you can see something that resembles a stomach, but is very tiny from the image that Chamba is showing us. So the moment you have a defect, always remember this, that the moment you have a defect, FGR just becomes part of your syndromic wake-up. It is not your main diagnosis. Your primary diagnosis becomes the defect which you think is underlying the baby. But the FGR is not your primary diagnosis here. FGR is only your primary diagnosis if there is no defect at all on the baby. So it is important for the baby to be thoroughly checked to make sure there is absolutely nothing else on the baby. Once you don't find anything else, then you go to your Dopplers. If your Dopplers are abnormal, then in that case, you are certain that you are dealing with a placenta insufficient condition, and that is your primary FGR diagnosis. So please take note of this. It's very important to be aware of this, that if you have a baby who is abnormally small, you measure the uterinatal Dopplers, they are all fine. From the history, there is no risk factor for placenta insufficiency. What do we mean? We are saying the lady doesn't have high blood pressure, doesn't have preeclampsia, doesn't have any other chronic illness. It's somebody who is super healthy. Suddenly the baby is small, but all the Dopplers, the umbilical, the uterinatal Dopplers, they are all normal and the baby is abnormally small. those cases should be referred to the fetal defects clinic so that we can look for defects, because it's more likely that there is an underlying problem on this baby rather than to say it's small because the placenta is not working. It could be that the genes are abnormal. Right. So I think thoughts are coming in now. Yeah, let's see. What cause, okay, this question has been answered. What cause FGR to be associated with polyhydramnios? So I think I've answered this. The presence of a small baby in polyhydramnios is an indication for referral to the fetal defects clinic. Why? Because it's likely that it's not, the primary diagnosis here is not FGR. The primary diagnosis is that there is an underlying likely chromosome abnormality. So remember this, that a small baby with too much fluid around it, it's likely that there's something going on. Right. More interesting information is coming on the chart there. Losartan acts on renin-angiotensin system during the second and third trimester pregnancy, reduces renal function, and increase fetal and neonatal morbidity and death. Yeah, it's a good gross summary that Chamba has put there. Well done. So the losartan story here is a very important story that we should never underestimate. I think of late we're increasingly seeing patients on losartan. I think it's something that our physician colleagues or even sometimes our obstetric colleagues may overlook when they're talking to patients with high blood pressure. Losartan is not a good drug for pregnancy because it damages not only the baby's kidneys, it suppresses blood supply to the kidneys, and this causes what we call more irreversible renal tubule dysgenesis, the tubules. I think they are what are called proximal tubules in the pregnancy, in the kidneys that are used to filtrate the fluids. Those are irreversibly damaged by losartan. And any baby exposed to losartan, they now have permanent renal failure. There is no baby who gets exposed to losartan who will escape the effects of losartan. So losartan, on top of that, it also causes pulmonary hyperplasia, and it may also cause something called hypocalvaria, where there is hypossification of the baby's skull. So, however, hypocalvaria is reversible. That means babies skulls can grow later on. So please take note that it is very important to ask the history. Ask the history in detail. Ask the patient, which drugs were you exposed to before? If somebody comes with a high blood pressure, ask them, which drugs were you given? Which drugs were you taking in first trimester? Don't just ask the drugs they are taking now. Because a patient could come to you at 32 weeks, for example. Here is because people took a good history. But you can see that the patient was allowed to take losartan all the way up to 31 weeks, which is really terrible if you look at it. Because the baby's kidneys were damaged beyond repair, and even if you check in the literature, you see that no baby escapes losartan if they are given for this period of time. Also in the second and third trimester, the deal will be done for the kidneys, and those babies will need lifelong dialysis if they are to live. But most babies die, actually, like in the case of our baby here. What if the baby has defects and FGR with abnormal Dopplers? One of the agreement in the fetal medicine world is that the moment a baby has defects, the primary diagnosis is not FGR. The primary diagnosis becomes the underlying chromosome abnormality or the syndrome. What do I mean by this? Let's take, for example, trisomy 18 babies. all trisomy 18 babies and triploid babies have FGR, but the diagnosis there is not FGR. The diagnosis there is trisomy 18. Are you getting it? The same with the triploid. Triploid babies are going to be FGR by 20 weeks. The diagnosis, your primary diagnosis cannot be FGR. FGR is now part of a number of defects that these babies have, and your diagnosis becomes triploid. That's your primary diagnosis. I hope I'm making it clear there that if you have a baby with defects, the primary diagnosis becomes the defect that you are seeing. And if you have FGR and a fetal defects, more likely there is an underlying syndrome there, whether genetic syndrome or chromosomal abnormality syndrome, like trisomy 18, triploid. All these cause FGR, sometimes with abnormal Dopplers, believe you me. So, yeah, I hope I've clarified this, that if you see a baby with defects and they have FGR, you cannot label this as an FGR baby who says this is fetal growth restriction with defects. No, the primary diagnosis becomes the most likely underlying syndrome. But if there are no defects, then your primary diagnosis is that there is fetal growth restriction. That's what the DOF consensus group recommend when we are managing, so that we all have uniform data. Otherwise, we will not be able to compare our data to others. Okay, so what do? I think let's continue the discussion. Let's hear what people think. Where did the polyhydramnios come from? Why suddenly polyhydramnios? I think the first scan, it's unfortunate, Sister Chamba, I don't know if you had images of the polyhydramnios, just demonstrate that there was no fluid. And the anhydramnios, the oligohydramnios, did you capture that image? Because people may not believe you that this baby oligohydramnios at first visit, but the baby had it.
Yes, unfortunately, I did not manage to capture the first images for the first scan, which showed oligohydramnios. I guess based on the report, the scan report.
All right. Do you mind if you go to, there's an image where you show the kidneys. Do you want to go to that image?
Okay.
Where you show the kidneys? I think it's there's something which is not right with those kidneys, which we can look at. I think there's an image which, yeah, that one. So if you look at these kidneys, you can see that these kidneys are enlarged and a little bit more echogenic. These are some of the effects you will see with losartan. I think it's more pronounced on the image on the left there. So these are some of the effects of losartan, which you have to be aware of. But when the woman is taking losartan damages the kidneys. The kidneys will look enlarged, may look more echogenic because they are also being hypoperfused. So they will look more echogenic than they should be. You know, the kidney should probably have more or less a constant as the liver if everything is functioning well, because they are well supplied with blood. But in case of losartan or angiotensin receptor blockers, they don't. So remember, losartan it's not just losartan. Other drugs that cause the same are drugs like captopril, enalapril. All those drugs, lisinopril, all those drugs do affect the kidneys the same way. So always ask if the woman is on angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Those babies are likely to suffer from permanent renal failure, irreversible renal tubular dysgenesis. So remember this, very important. Let's get the comments. The comments are coming. Okay, no, so will the FGR due to chromosome abnormality be asymmetric or symmetrical? To be honest with you, the best way to answer this question is The reason why you see we don't really put a lot of emphasis on asymmetric or symmetric FGR ourselves is whether the growth is symmetric or asymmetric depends on the onset of the insult. Cases of placenta insufficiency, if the insult is very early, like we see in our region here, which is not common probably in European countries, sometimes you see these women with very bad hypertensive diseases as early as 20 weeks. And the baby is already being insulted by that high blood pressure. Certainly, those babies are going to have symmetrical FGR because the insult is very early. However, the typical FGR that you are all used to happens late, and you are going to see asymmetric FGR, whereby the tummy and the femur are the ones that are small. We do not want you to think along those lines of saying asymmetric and symmetric FGR, because in our environment, you may misdiagnose the early onset, very, very early onset placenta insufficiency secondary to hypertensive disease, because we have those cohort of women who at 22 weeks, the blood pressure is so elevated, the placenta is gone and the baby is not growing. So just understand, people used to use this a lot, but I want you to know that there is a trap to thinking like this, that if you think like this, you miss the cohort of women we have in our region here, which is the early onset disease, or those women with uncontrolled high blood pressure who fall pregnant, where the placenta is already damaged by 20 weeks. We are going to get symmetrical FGR there, even if it is the placenta. Typically, it is written that chromosome abnormalities will give you a symmetrical FGR. That is what is expected, because the head is going to be small in conditions such as trisomy 18 because of the strawberry shaped head. So you're going to have what looks like symmetrical FGR, but be aware that placenta conditions secondary to hypertensive diseases, if it happens early, can also lead you to symmetrical FGR very early. And besides, you cannot use fetal growth restriction on its own for chromosomal profiling. You need other defects. So you can't just look at the baby and say this baby is small, so there's likely to the symmetrical FGR, it's likely to be chromosomal in nature. You need associated defects. But very early onset FGR cases should all be referred to the fetal defects clinic, so that we check carefully for defects, because that's the most likely cause. Although we know we have a cohort of women who have early onset hypertensive diseases locally.
So, Dr. Werenga, for this case, can we say that maybe there is both the effects of losartan and probably some syndrome causing the tracheoesophageal fistula, the microcephaly? Over to you.
Yeah, I think for this case, we can think openly about things that losartan could do, which may not be reported in the literature. It also came across my mind, even the polyhydramnios. I thought the polyhydramnios could be due to the diuresis that follows permanent renal damage. This is what I thought for this baby, because the presentation is weird. At first, losartan shut down the kidneys. Then when losartan was stopped and the woman put on methyldopa-nifedipine, it looks like the kidneys opened and began to urinate again, but in excess. So I'm thinking that that is the diuresis that follows renal failure. that happened here with the baby. Then the failure to swallow. Well, losartan is acknowledged that it may cause pulmonary hypoplasia. The literature did not reported on its effect on the trachea, on the esophagus, but I think this case probably may also make us think that way and say, could it also cause issues to do with the baby swallowing? Because this woman took losartan from first trimester. So the people used to think losartan doesn't cause anything in first trimester, but it still damages the kidney second, third. But I think we need to really think and say it could be causing other things as well. The unfortunate part which we have, which is still a disadvantage in the way we are practicing fetal medicine locally, is our failure to investigate cases up to their logical conclusion. If we had done an amnio in this case and ruled out chromosome abnormalities, this was going to liberate us to think the way we are thinking right now. We're knowing that we have ruled out common chromosome defects. Using the syndromic pattern, it's very difficult to pinpoint one chromosomal defect for now, because we do not have enough. Lots of supporting trisomy 18 can still be a possibility to what we have, but we would have wanted more things to be very concrete with the trisomy 18 as a possible cause. So our lack of investigation capacity affects how we can think. So and then the other thing that could have helped us, which probably future presenters should try to do, if you could get more information from the neonatal team in terms of what investigation they did, especially for this baby. We're interested in the renal function. We're interested to know if they've done any skull x-rays, and also we're interested in knowing if this baby was able to feed, because we're querying that they could be tracheoesophageal fistula or even esophageal atresia here. So we're interested in knowing all this information. So maybe Sister Chamba and team, if you guys could try and get information or data for this patient, because this is a very interesting case which you can write up and which you can also present in other bigger forums, really, because it's a very interesting case. So try to get this data from the neonatal team, so that we add more flesh to the case, but it's a very interesting case. Then the other thing that could have helped us, if we could do post mortem to these babies, especially to look at those organs, including histopathological analysis of the kidneys, and that would be help in terms of giving us the right answers. Then may you please elaborate more on microcephaly versus FGR of the small head? Right, that's a very good question there, Sister Mplanga. One of the things which you should always be aware is that whenever the head is small, and the head is small, the head should never be small, right? It should never be small. If you have a small head, especially extremely small head, less than the third center, it is likely that there is something serious or underlying chromosome abnormality. So this case should be referred to the fetal defects clinic. Small heads are normally found with chromosome abnormalities which we are highlighting, like trisomy 18 and trisomy 13. You tend to get small heads. We may also get microcephaly. Microcephaly is secondary to things like infections and other brain abnormalities like neuronal migration disorders. I think you remember these terms when we were doing the CNS abnormalities. The videos are there on our YouTube channel, Fetal Medicine Foundation Zimbabwe. You can watch those ones. So a small head is not a good thing. a typical FGR baby, secondary to placenta insufficiency, will not have a disproportionately small head. In most cases, the head will grow within normal or just on the borderline. But it should not be very small, like being below the third centile. If you see a head which is below the third centile, of course, always revise your dates. Make sure that the pregnancy is well dated, because that is the most commonest mistake that you can do. Wrong dating, and it will make the baby head appear small. But if you are certain with your dates and the head is small, know that you are more likely not dealing with FGR by the strict definition of what an FGR is. Like we were saying, unless if you have this early onset hypertensive diseases, which start at 20 weeks. Besides that, you are more likely not dealing with the typical FGR. You are dealing with something else here, which is either a chromosome abnormality or a genetic syndrome. Because most genetic syndromes will give you small heads, right? So yeah, I think that's my explanation there, but that's a very good question there. What way, unfortunately, the couple didn't afford this test, Dr. Mabembo. They couldn't afford any of the tests, so they were not done, both the OGTT and the torch. So this is where we are coming from to say, our background is that we are incapacitated in terms of investigations. So we are limited in certain situations. We can't go deep enough until we reach a logical conclusion of the case. So yeah. So I think do you have any more comments on the case? But this is a very good case. We want to encourage you guys to come forward and present. Look, most of this is your work, and it's good to showcase your work, what you are doing, because it also shows that you are thinking as you are seeing the cases, and it's a good learning opportunity for everyone, because not all of us will come across a case like this. But once the case is admitted, it will make everyone clever, everyone more, more knowledgeable and more vigilant when they see more or less similar cases like this one. So we highly recommend you to present what you are going through. Like we say that if you want to present, just let us know. Then we help you to make it happen so that you can present. Otherwise, very good case and well done, Salim Mugabe team. Thank you so much. Please take note that we were hosting a training on labor monitoring. I called for some volunteers. I think I have only one volunteer who came through. I kindly encourage you to volunteer. You will not prepare presentations because presentations are already there. It's a matter of just presenting on Dopplers, presenting on basic biometry, then presenting on things like checking the presentation for women in labor and so forth, and also doing demonstrations, because we will do some few demonstrations to the participants. Who are the audience? The audience are labored sisters, probably early labored sisters at Salim Mugabe for this training, and also registrars in obstetrics and gynecology. We are trying to improve the care of women in our labor because of late we are losing a lot of babies. There are too many early neonatal and late neonatal deaths there happening now. Fresh stillbirth and motherless stillbirth happening for babies who they've come with a heartbeat in our wards. So we think by doing this training we can improve the situation a little bit. So please come forward. The training is there on Tuesday. Probably we will have 2 sessions. This first one and another repeat, so that everyone who works in this department is trained. Those at Pari, you may wonder and say, why not Pari? Pari will come probably in March. We'll do Parinyato as well. So please.
Yes. Thank you. Okay, I just wanted to say thank you, Dr. Merengen. Thank you, fellow colleagues, for listening. So I just wanted to add on to the outcome. I only managed to call the parents, and they were saying that the baby was newly oral from the time of delivery, but of course, there were some tests which were ordered, but none of the tests were done on the baby. The reason not known. I think I'll make a follow-up with the NNU team, just have to check out what was actually written by the pediatricians. It's only that I was communicating with the the parents.
Ah, great. So what you can do, Sister Chamba, please keep this case, or you definitely present this case in another fora. It's a very interesting case, very thought-provoking and also eye-opening, which will help in terms of management of patients like this. Thank you so much.